This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast, November 2024, and we're back. Ryan, how you doing?
Excellent. And November means we talk about what we're grateful for, and talk about being grateful for. I'm grateful for you, Rory, and I'm grateful for this podcast, and I'm grateful for all you listeners.
Yeah, you took all my things. So
yeah, there's nothing left to be grateful for.
There's nothing left. Annals and our listeners and you. All right, let's hop into it. Our first article, temperature control parameters are important. Earlier pre-induction is associated with improved outcomes following out-of-hospital cardiac arrest. And the lead author is Rachel Beekman. So targeted temperature management was all the rage for quite some time. But our enthusiasm has been cooling, as subsequent trials have failed. As subsequent trials have failed to reproduce the benefits demonstrated in earlier studies. Now, these authors propose that the inconsistency in outcomes is based on an inconsistency in the application in TTM and basically the time it took to actually initiate targeted temperature management. And if we were more precise and more swift in our initiation of targeted temperature management, we would see better outcomes. So they conducted a retrospective single center study where they examined consecutive out-of-hospital cardiac arrest patients treated with targeted temperature control 2014 to 2022. Pre-induction was defined as the time from hospital arrival to the time that targeted temperature management was initiated. Door to temperature control, or DTC. Early DTC was defined as less than 3 hours, and late DTC was greater than 3 hours. And then they simply just measured the association between good neurological outcome to the door to temperature control time. Overall, they had 347 patients included in this study. Unfortunately, only 75 or 21% actually met criteria to be considered early DTC, where the median time to temperature control was 2.5 hours. While the late group was the majority of the patients, 272 or about 78%, where the median time was about 5 hours. Using multivariable logistic regression, the authors found that early DTC was associated with improved good neurological outcome, which they defined as a Glasgow outcome score of 1 or 2. And so, all in all, pretty simple study, pretty simple outcomes. I think the big problem is because of the fact that it's a retrospective single center study, it's really impossible to say anything about the fact that better outcomes were because they had earlier time to temperature control. There's multiple confounders that this could be done with. Obviously, sicker patients have more things that have to get done to them before you can actually institute targeted temperature control, and thus are going to have worse outcomes. And so it's really hard to actually associate this. Moreover, we actually have a couple of really good randomized control trials that looked at targeted temperature management pre-hospitably. So the patients got cooled in the ambulance as they were coming to the hospital versus waiting till they got to the hospital. And they found that these patients got cooled much faster than the ones who were in the hospital, but outcomes were exactly the same. It's really hard to say much from this study. And I think overall, the more studies that are done on targeted temperature management, the more we're seeing that targeted temperature control is probably less and less important than we initially thought.
I think you need immediate cooling. This is, you got to go take your whatever jet aircraft in Captain America and go straight into the ice. And that's the only way to cool somebody effectively, as we've learned. He comes out totally neuro intact and stronger than ever. So I think that's the way to cool people. This is just an idea that just will never die to some extent. They're going to keep on iterating this concept, and until I don't know until they've cooled just specific like the brain or something. I don't know. They have like little helmets. They'll try everything to get people cool. I know we've seen the helmet trials. The ones that goes like puts the fluid up in their nose and things like that. And these obviously the authors on this one are part of the ICE-CAP trial, which is another randomized trial trying to get initiation of targeted temperature management sooner than the previous trials. So, we'll keep on seeing things like this. And this is hypothesis generating and foundation generating for future trials and future grant submissions. And then we'll just have to keep on waiting for the best evidence to come out of the randomized controlled trials to decide what to do with it. This doesn't move the needle on anything, but it helps advance the science, I guess, for trying to figure out the best ways to deliver this if there's going to be a chance of targeted temperature management helping.
Yeah, my problem with most of the targeted temperature management studies is we ignore the negative ones or find reasons why they don't apply. And these can be like really small reasons, questions on their external validity, right? Like, well, the patients in Norway don't represent the patients in the US, right? They have way more bystander CPR. These
They've
are
got a lot
not
more
our
brown
patients.
fat as
Yeah.
opposed to regular fat because they're always so cold up there
It's
in
already
Scandinavia.
cold there, right? Right. Like, so there's really like questionable attacks on the external validity of the studies. And then when you have studies that are positive but have serious flaws in their internal validity, like there was no control group or it was a retrospective study, we just kind of ignore those really, really important factors questioning its internal validity and accept that it's true, right? And we almost just work backwards, right? We had those two studies, Haka and Bernard, early on. I think it was like 2000 or 2004 that they came out in New England Journal, both of which were, should be hypothesis generating. Their control groups really didn't have much of a control. They had outcomes that were way better than any critical care trial has ever shown before. And you have to wonder, maybe we should do this again and replicate it. But instead, we accepted targeted temperature management were the thing. And now we've been working backwards. We just changed the actual level of targeted temperature management. It's like not 33, now it's 36. Oh, it's not 36, now it's 37 and 0.5. Rather than being like, hey, wait a minute, maybe this isn't a thing at all, and we've just identified a better control group.
So what do you do at your hospital, Rory?
37 and a half.
So you just fever management then?
Yeah, we just don't let them get hot.
Yeah, I see it. Okay. Yeah, same at our hospital. But that may be a funding issue. We just can't afford the cooling the cooling things. Anyways, all right. We'll move on to our next article, also about out-of-hospital cardiac arrest. This one is called "A Simple Scoring System for Identifying Favorable Neurologic Outcomes Among Out-of-Hospital Cardiac Arrest Patients with Asystole." Our lead author here is Hannah Park, and she's at the University of Ulsan in Seoul, Korea. This is another one of those studies making an effort to reduce the amount of futile care provided in health systems. Out-of-hospital cardiac arrest already has a dismal survival rate, and one of those poor prognostic features being an initial unshockable rhythm, with asystole being about as mostly dead as someone can be. These authors from South Korea take their registry of out-of-hospital cardiac arrest and look specifically at this asystole population to identify prognostic features for good neurologic outcomes, and then use these features to attempt to create a classification scheme for a good chance of survival. Out of their cohort of out-of-hospital cardiac arrest attended by EMS, there were 6,322 patients with a medical cause for their OCA, who also had return of spontaneously circulation at some point, representing effectively that population where we might have a question regarding the durability or desirability of survival. The list of potential features for their predictive model were derived from the Utstein elements and the previous literature. And in this specific cohort, those elements that shook out as most predictive are fairly recognizable. Younger patients, witnessed arrest, bystander CPR, a quote-unquote short call to hospital time, and any time they had return of spontaneous circulation in the pre-hospital setting. So they use the odds ratios associated with each of these different predictive features to create a little model. They call it the WBC asystole score. Higher is better. And the lowest scoring cohort had a 1.3% chance of neurologically intact survival, while the highest scoring cohort, the one with the most best prognostic features, was up at 12% survival. The most influential member of their survival curve by far was pre-hospital return of spontaneous circulation, which worth 5 points when 5 points was actually just their threshold for the highest survival cohort. So there you go, another OCA survival model. There are going to be some idiosyncrasies relating to the specific nature of medical care in Korea, in which the pre-hospital bias is definitely scoop and run. The population density is high. For the purposes of their model, they chose dichotomous cutoffs for young, so it's not a continuous variable, and their dichotomous cutoff was age 65. So I'm still young. It's nice. And short transport, which was less than 20 minutes. So that's what they say. That said, if you are tasked with rationing care in some fashion, or would like to just have some evidence floating around in the back of your mind when considering whether to continue resuscitation, these features can add a little bit extra to your gestalt. I mean, it has pretty decent face validity that an elderly person without witnessed arrest, without bystander CPR, who is still in asystole, is almost assured of having a poor quality of life, even if you get ROSC at some point. It's just not going to be good in the short term or the long term. This specific rule, however, I expect will just remain nothing more than an academic exercise and an example to guide future efforts.
Yeah, I mean, one, it's sort of a self-fulfilling prophecy. If like you make it, you're alive by the time you reach the hospital, yes, you're more likely to be alive by the time you get out of the hospital than if you're not alive by the time you make the hospital. I mean, their results are still pretty bad. 12% survival is not wonderful, but it's fairly in line with, I think, every other data set that we've looked at like termination of resuscitation rules that, unwitnessed, non-shockable rhythms that don't have ROSC pre-hospital do badly. All right. And so I think this is fairly consistent. If they've made it to the hospital and you don't have ROSC and it's asystole, your chances of getting them back with meaningful outcomes is very, very small.
Yeah, these kinds of rules I think are more for health systems that like really have difficult problems with pre-hospital termination of resuscitation, and I think that's the main issue here in Korea is that they just do not call patients in the field. Lots of other places they'll happily terminate resuscitation in the field if they meet criteria. Whereas I think this is kind of the foundation for them maybe changing their health policy in their country. So I think that's where the point of this comes from. Not so much that's generalizable to other places to adopt this rule, but it informs their specific care population.
Yeah, but I do think it's fairly in line with most of the termination of resuscitation rules you see, right?
It's the same features.
Yeah, asystole, non-shockable,
No
unwitnessed.
ROSC, old people.
Yeah, you're pretty much not going to have a meaningful outcome.
Not going to happen. All right.
Shall we move on to our next one?
Yes, our best one.
Our next article is Implementation, Clinical Benefit, and Safety of D-dimer-Focused Pulmonary Embolism Testing Pathway in the Emergency Department. And the lead author is Federico Germini. This is a curious paper, essentially looking at an implementation of a PE diagnostic strategy, which includes the use of a D-dimer, and if positive, followed by a CT pulmonary angiogram. The authors essentially conducted a prospective multi-center implementation study using 2 emergency departments, where they essentially used a pre and post design of this implementation program when they implemented basically a PE diagnostic pathway. And so they compared the pre and post implementation periods as well as an outside hospital for their controls. In detail, the strategy was fairly simple. If patients were suspected of having a pulmonary embolism, they underwent D-dimer testing. If the testing was 500 or greater, they then went CT pulmonary angio. If it was less than 500, they didn't undergo any further imaging. I think this is a fairly standard strategy that most of us are fairly comfortable with. They included consecutive adult patients, so age greater than 18, and they identified them by using one of 13 pre-specified triage system codes that they thought was in line with pulmonary embolism. They defined being tested for PE as receiving either a D-dimer blood test or CT PEA imaging or VQ scan in the emergency department. And then they essentially looked at the proportion of patients that were adherent with their pathway, the proportion of patients that ended up receiving imaging for pulmonary embolism, and then any missed pulmonary embolisms over the next 30 days. They enrolled patients from 2018 to 2021. Overall, over 16,000 patients were tested for PE throughout these hospitals over that time period. And it essentially split up pretty evenly between the 3 groups, 33.4% in the post-implementation group, 30.7% in the pre-implementation group, and then 35.9% in the external control sites. And adherence to D-dimer in the pre and post period was actually fairly high. Pre-implementation of the study was 91.3%, and post it was 97.6%. The number of patients undergoing CT imaging really didn't change throughout. In the pre-period was 38.7%, in the post-period was 35.8%, and the control group was 37.8%. Interestingly, the rate of patients with imaging who did not have a D-dimer ordered or the D-dimer with less than 500 was different in the pre-post group. So in the pre-period, 22.5% of patients essentially went straight to CT scan, didn't use a D-dimer, compared to only 6.7% in the post-period. And so if you think about that for a second, if the total number of scans were similar between the pre and post implementation periods, and yet in the post period, more patients had D-dimers ordered, you essentially created a protocol that encouraged the clinicians to order more D-dimers. And it seems like they were ordering D-dimers in patients that they otherwise would have probably just gone straight to scan. And then since that didn't really reduce the number of images anymore, you have to think, hey, these physicians are pretty good at saying this D-dimer is not going to help me in this patient. It's going to be positive. I'm going to need a CT scan. Overall, they missed 2 cases of PE at 30 days. Actually, both these patients had CTPA imaging at the time, so they weren't D-dimer misses. And then obviously the rates were less than 1% in the misses pre and post. And so, we can say this strategy is fairly safe. So all in all, I think it's an interesting study. I think it's somewhat curious. It's not surprising to me that they didn't find much of a difference. To me, this is a fairly routine strategy that has been used by emergency physicians for a fairly long time. And as you see, the actual compliance with this rule was fairly consistent pre and post, meaning you probably didn't make that much of a difference in your actual D-dimer strategy or in your PE workup strategy by implementation of a strategy like this. So it's not so surprising that you really didn't reduce imaging. I think if they had gone with some of the more novel ways of using D-dimer, like either age adjusted or the year score or something that allows you to use the D-dimer and try to play to its strengths and reduce its weaknesses, which its specificity as best you can, you might have seen better results. And then the other thing, of course, is like anytime you enter people into a PE pathway, you're going to increase their amount of scans, right? And so the overall rate of PE in this cohort was only 4.8%, meaning, they tested a lot of patients for PE. And so strategies that kind of actually get people not to even go down the pathway at all are probably going to have better effect than something like this.
Yeah, and I mean, I think the most interesting thing here, I mean, there's a lot of numbers in this table here that you can go review on in the study document itself in table 2. The most interesting thing to me is actually this whole the whole line of no imaging when D-dimer is greater than 500 nanograms per milliliter. It's like the 34% of the patients who had positive D-dimers didn't go and get imaging in the control site. 42% and 49%. Like that's a big chunk of this population where they were quote unquote potentially screened for PE, had a positive D-dimer, and then didn't get any imaging, which makes me think there's a huge chunk of this population that they studied that could have dramatic effects on the rest of this table if they'd imaged more patients or imaged fewer patients or whatever the behavior was with these clinicians who did these D-dimers at this point. So there's a huge step at that screening point where they're bringing people in and deciding to screen them for PE that is somehow capturing a third of the cohort that they don't carry on and actually complete the evaluation for PE, even though their D-dimer is positive. So I think that kind of that calls into reliability for me a lot of these results.
The way I imagine that happen is you've got a doc at triage who's just ordering tests, and you get people who they meet some concern for PE. They order a D-dimer. The clinician when they sees the patient in the emergency department says this patient doesn't have a PE and doesn't further the workup. But you're right; they probably should be excluded from this cohort entirely. The treating clinician ended up not having a suspicion for PE because otherwise, how do you justify a positive D-dimer and not going any farther?
Yeah, I mean, I think you should be studying a cohort in which you actually suspect the patient has a pulmonary embolism and to decide if this is a useful strategy, and that's a third of the population that basically shouldn't be in this trial or this report to some extent. So yeah.
It speaks to their, how they identified patients, right? They weren't enrolling patients in the emergency department that the clinician thought had a PE. They were going back afterwards and looking and then trying to use charting and coding to identify patients that seemed like they were patients who went through this process.
Lots of limitations. So we'll go from this one to the next article, also pulmonary embolism again. This one's called Characterizing Acute Pulmonary Embolism Cases Diagnosed at an Emergency Department Revisit Using Statewide Clinical Registry. Our lead author here is Arthur Jenk, and they're at the University of Michigan. And well, now that we've discussed the pursuit of sensible ways to minimize unnecessary testing with potentially acceptable miss rate, let's get some whiplash here by talking about groups that are concerned about missing too many PEs. And this is one of those quality studies using the so-called look-back method, using symptom disease pair analysis, or SPADE, in which events are identified, and then a time period prior to those events is examined to determine whether someone can be found to blame for missing something. In this retrospective analysis from 40 emergency departments in the Medic Registry, which is in Michigan, The authors identified 24,525 diagnoses of acute PE. These 1,202 had an emergency department visit within the preceding 10 days. So, thusly, the authors conclude 1 in 20 patients with an acute PE was associated with this short-term ED visit, and in their terminology, may represent missed diagnostic opportunities, code for diagnostic error. As amusingly as inflammatory as this sounds, this 1 in 20, it's actually an improvement over the grossly flawed Agency for Healthcare Equality publication regarding the harms of diagnostic error in the emergency department, which proposed up to 1 in 5 patients diagnosed with a venous thromboembolism may have been missed at a recent ED visit. And combing through their data and the rest of their well-reasoned discussion, it's actually clear that even this 1 in 20 number is a ceiling. And the authors actually are suggesting only a small number of these prior visits represent actual missed diagnostic opportunities. For example, their number 1 and number 3 discharge diagnoses from an ED visit prior to PE diagnosis were COVID-19 related, which, yeah, could have been a PE, or it could have just been acute COVID, a condition known to increase the risk for subsequent venous thromboembolism. But while most prior ED visits were not obviously associated with a missed diagnostic opportunity, there are certainly a few clues in there as to patients whose initial visit could have been PE or VTE related, as a few of the other first visit diagnoses include things such as pain in the leg, pain in knee, unspecified dyspnea, shortness of breath, etc., etc. But on the flip side, these data can also do not reflect whether those suspicious sounding diagnoses were also, at the time, accompanied by an entirely appropriate evaluation for PE or VTE. So, a little hard to make anything out of that aspect of these sort of this look at this data. And maybe the better window in which to view these data is the corresponding context where only 2 in 10,000 ED visits were associated with a subsequent diagnosis of acute PE, meaning missed opportunities to diagnose PE are really rare, and almost certainly rarer in our so-called zero-miss cultural environment. And it is likely reasonable to just stick with the evidence-based protocols we currently have developed and not panic.
Yeah. No good can come of a study like this, right?
Well, this is actually a response to a worse study. So this is actually like the good news compared to the Agency for Healthcare Research. Like, we're killing 300,000 people a year with diagnostic error in the emergency department.
But it goes about it all. It's looking at the cases it's looking at the needles and not the hay.
It's a spade. It's look back. Yes.
Yeah. And it's like, yeah, there's going to be patients who have a PE that had multiple presentations to diagnose that PE. One, the mistake is not missing a PE. It's missing a PE that kills or does severe harm, right? And so that's the first thing. Two, it doesn't talk about the other thousands of patients that didn't have a PE that underwent the same workup, that we did not harm them by giving them CT scans, giving them false diagnosis, so on and so forth. And three, we have lots of evidence, thousands and thousands and thousands of patients demonstrating that if you go through these PE pathways, you are not going to miss clinically significant PEs at a high rate, right? And so when you do it this way, it just hyperinflates these risk factors and just instills so much anxiety that doesn't need to be instilled.
Yeah, it pulls out these like little diagnoses, like, oh, did somebody with a leg pain, they could have had a PE that first visit, couldn't they? Just like all those little things. They could have. This is what you do when you're in quality and safety, is you look back like this and see if there's missed diagnostic opportunities. But yeah, so this is why, for example, there's the HRQ thing also talks about diagnosis of dizziness in the emergency department, and how many of those patients are like acute basilar strokes or cerebellar strokes. And if you look at a look back sort of methodology, you find that, oh yes, these patients all went to the ED for dizziness within a couple of weeks. If you look at the all comers to the emergency department and it's all the dizziness and lightheaded and disequilibrium patients, we're missing like 1 in 10. We're doing great. We're never missing this diagnosis unless like the rarest of occasions, and even then, like it's not a guarantee they had that stroke when we saw them. So it's a different way of looking at it. Yes, that it inflates the numbers, but I think it's also funny that this is actually less inflammatory than the previous the data. So there you go. nobody's missing PEs like this. It's just we're not endangering the public.
No, I mean, we're probably missing a small amount of PEs, right? Like
And we're
that's
over
gonna
testing
happen.
for PEs.
Totally, right. Like, but like us testing more is not actually going to catch these PEs, right? If you actually look at the last study reviewed with the D-dimer strategy, the PEs that were missed both underwent CTPA imaging, right? And so even if you do the whole pathway, you were going to end up missing some PEs. You're just going to break
you
the
didn't miss
system.
a PE. You had a 30-day return, which is totally different.
Right. Well, I mean, you can miss it. I mean, the sensitivity of a CTPA is not perfect, right? We could conceivably miss some PEs on them, right? No test is perfect. The goal is to treat patients the best way we can without harming them or breaking the system, right? And and if we are to scan everybody who walks in with any symptoms, I think we're doing our patients and us a disservice.
Well, luckily we haven't broken the system yet. Or harmed any patients with overtesting yet.
Oops.
Oh, well.
All right. Next
Moving
article. Trends in initial anticoagulation among U.S. patients hospitalized with acute pulmonary embolism 2011 to 2020. And the lead author is our friend Lauren Westphal. But I think the guidelines for some time have encouraged us to be using low molecular weight heparin or oral anticoagulants when treating pulmonary embolism rather than unfractionated heparin. Some of the evidence supporting that can be debatable, but really it's more consistent. You get more consistent anticoagulation, you have less bleeding and better outcomes. And that's the justifiable reasons for such guideline recommendations. And so these authors essentially just wanted to see how we were doing at following these recommendations. They conducted a retrospective study using data from over 1,000 acute care hospitals in the United States that contributed to a database called the Premier Healthcare Database. They looked at individuals 18 or older and included cases who received a diagnosis of acute PE, underwent imaging for PE, and received anticoagulation at the time of admission. That's an important part. So they had to be when they were admitted in the emergency department. And then they essentially looked at what initial anticoagulation was selected for treatment. Close to 300,000 cases were included in this data set. Again, between 2011 and 2020, actually, when you look at it over time, the proportion of patients who received between 2011 and 2020, the proportion of patients who initially received treatment with unfractionated heparin actually increased from 41.9% to 56.3%. So conceivably, we've been doing worse. And the amount of patients that received low molecular heparin, not surprisingly, was reduced or went down from 58.1% to 37.3%. Some of this makes sense. If you look at the patients who are more likely to receive unfractionated heparin, the factors that increase the risk of receiving unfractionated heparin, admitted to the ICU or step-down unit, being treated with mechanical ventilation, essentially all the factors that would make you think that the patient was sicker, received thrombolysis, received vasopressors, had chronic renal disease, where obviously concern is the clearance of low molecular weight heparins. So, I think in some ways you can look at this and say we're not doing a great job. In other ways, I think this data set is somewhat limited to truly say that. And I think from a couple ways. Remember, these are patients who had to be diagnosed with a PE on presentation in the hospital, and they really looked at what anticoagulation was used for initial treatment. So the initial treatment they given. And, there's no absolutism in this. You can be started it on unfractionated heparin and switched over to low molecular heparin on day 2, and you would be missed in a study like this. And you can see the patients that the clinicians were most concerned about. So the ones going to the ICU, the sickest ones, got unfractionated heparin, and that's because you can easily turn it on or off if the patient needs a procedure, like they need to go get like clot extraction or have a catheter-directed thrombolysis, or are going to get thrombolysis where you can turn your heparin off and decrease your risk of bleeding. It's obviously better to use unfractionated heparin. So I'm not sure this gives us the full idea of what's happening. I think the other thing that you see, from 2011 to now that may have contributed to this is order sets. There's order sets. We have an order set for treating pulmonary embolism, and when you open it, page where it is auto-filled with unfractionated heparin. And so this might not just be the practice of clinicians that are changing, but how order sets are governing our care as well.
Yeah, I think the other thing that this study kind of misses is, well, it's just the inpatient hospitalization patients, well, and the observation admission patients. So it's patients, it may be selecting for a group that's sicker over time from between 2020 or 2010 and 2019. Whereas potentially we're sending a lot more of the well patients home, the ones who may have otherwise gotten low molecular heparin when they got admitted to the hospital, the younger PEs, et cetera, and they're going home on oral anticoagulation instead of being admitted to the hospital. And that's changing the proportions a little bit. But the whole demographics doesn't totally reflect, like, it doesn't, the patients are not obviously super sicker. They're a little bit sicker in 2019 than they were in 2010. Not enough to make the big difference, I don't think, in this study. It doesn't really show us the whole picture either way. Certainly, it's a good picture to look at and go, why is it happening? And that obviously this will prompt further study with different methods to try to evaluate whether this is appropriate, or whether the population that's being admitted is really changing that much, or whether, like you say, it's like the diagnostic, it's like the inertia of order sets and different things, and trying to get to the bottom of it. But if we don't know this is happening, and this is like a snapshot that says, oh, this is happening, we don't even know to investigate or to fix it. Okay, let's move on to our final one here. This one is called Development of Clinically Validated Artificial Intelligence Model for Detecting ST Segment Elevation Myocardial Infarction.
You just couldn't help yourself. You couldn't help yourself.
What do you mean I couldn't help myself? I didn't publish this article. I'm just the victim here.
Yeah, you poor victim.
I didn't put this one in the November issue. I just have to tell you all about it.
Annals podcast cannot be complete without a machine learning study reviewed by Ryan.
Every journal is full of these sorts of models. Anyways, this is Sang-Hyup Lee's article from Yonsei University College of Medicine in Seoul, Korea as well. And as you say, we're machine learning again. This time it's STEMI. And the source data here is a Korean angioplasty registry spanning 2006 to 2020, with patients excluded if there's no paired coronary angiography data. Paired suitable. They're trying to pair angiography data with an ECG. They trained their model on basically years 2006 to 2019, and then used a few different sets to validate this model that they derived from these angiography ECG pairs. They took that year 2020 of angiography paired registry data. They had an external German database of ECGs, and then finally they did these like clinical evaluations within their own emergency department using all chest pain ECGs from a year in their emergency department. So they had all these different things, and they also performed a couple comparisons in addition to all these different validations, one of which to their unnamed commercial ECG machine read. So like that printout you get from your ECG machine that says, like whatever is left axis deviation, possible, whatever STEMI, or possible, it gives you the star, acute MI. And to then 300 ECGs read by some second year emergency medicine trainees, because, we're just comparing it to everything. And then lastly, they also evaluated their model using a technique called GradCam, or gradient weighted class activation mapping, to try and sort of look under the hood at these sort of black box machine learning models to see which parts of the ECG tracing were actually sort of being focused on, or most affecting their model outputs, as sort of trying to get this element of explainability. So, with all this derivation, validation, and comparison, there are obviously a lot of results, which are too laborious to go through in detail. The basic sort of results, and like I say, you can go onto the website and you can find this article if you'd like it. The AI model they built was far superior to both the commercial ECG machine and the second-year trainees. However, while their model was roughly 95% sensitive and 90% specific when used on their local data, sensitivity dropped to 83% on the external German database, although specificity improved to 98%. So there's still some generalizability and some maybe overfitting or training or something specific about the way that their ECGs are traced in their registry that may not be able to generalize this to other systems. So on one hand, without going into all the details of the performance of this algorithm, it's pretty clear it's not going to be entirely clinically acceptable as an autonomous agent. Missing more than 1 in 20 STEMIs is not great. And with thousands of chest pain ECGs every year, specificity probably has to be better than 90% as well. But this performance is really not atypical for these sorts of models, and considering a best available human operator standard, it may yet outperform clinicians in many settings. So the real key, like any of these decision supports, is how the output of this model could be incorporated into clinical workflows, And I'd like to argue ideas like changing this from a dichotomous STEMI, not STEMI, to a measure of probability could be potentially informative, using their GradCam visualization to highlight parts of the ECG, which the AI was making its predictions, could be useful, almost educational, and other aspects that could help clinicians make decisions rather than trying to autonomously make the decision for them. And then the need for true measurement of the effects and unintended consequences of a real world deployment of this model, not looking just at clinical accuracy, but the operational and cognitive impacts. So, a lot to unpack from a paper like this, and a typical discussion we have almost at every predictive model review here, illustrating that grand gulf between the performance in these sort of test sets and the real world impacts.
I think that's exactly right. I think the problem is comparing this with perfection, and that's not what you need to compare it with. Like you said, you need to compare it with us, who are already overburdened in the emergency department, task saturated, doing other things. And while I'm intubating a patient, having an EKG shoved in front of my face and asking me to sign it. And we are nowhere near perfect either.
With
And
the
so
blade.
the question is, how well does this perform in comparison to clinicians working at the bedside? And so it doesn't have to be perfect. It just has to perform fairly similar to us, which I don't think would be that difficult. And if it can, that means we don't have to sign countless EKGs on our shifts.
Yeah, like I said, there's a way to take a model like this and instead of just being, say, STEMI, not STEMI, you can say like 90% probability STEMI, 10% not probability STEMI. Everything else requires some human review with some augmentation. And then 90%, you don't have to sign it. You can just like activate the cath lab, like whatever it is. The 10%, you don't have to sign it because it's not a STEMI. Like there's ways to reinterpret these data and potentially reapply them as a useful tool. And maybe they can do that. And then there's that best available human operator standard that you're talking about. In the United States, it's an attending physician, a board certified EM doctor. In most hospitals all the time, it's changing. There's more nurse practitioners, advanced practice practitioners, so on and so forth. But there's a lot of ABEM people in hospitals. In other countries, it's a lot of trainees in hospitals, even staff in the emergency departments at night or after midnight. So they need some of this augmentation to keep patients safe. There may be more of a market for that outside of, and then beyond modern health systems, like there truly isn't much of a medical infrastructure. Then things like this become really, really valuable.
Yeah, I mean, the other way is this is looking at the performance of this test in a vacuum and isolation versus like you've got someone at triage with a trained triage nurse looking at them, and they look fine and they have a low risk EKG as determined by this rule or this AI generated evaluation. No one needs to look at that EKG. On the other hand, if they look awful, yeah, maybe you should take the EKG and put it in front of someone to take a look at, right? And so I think this can be kind of worked into a triage system where you're reducing the amount of burden on the clinicians.
Yeah, so what you're talking about is multimodal artificial intelligence now. Because it's interesting because they did a study. Jeff Klein, I think, did a study like about 15 years ago where they took pictures of people's faces, or like when they were investigating for pulmonary embolism, and there were like certain facial expressions that were associated with PE and certain ones that were protective. So hey, take a picture of the guy at triage who's got the ECG, and then is this guy having a STEMI or not? Because it usually looks like you're having a STEMI when you're having a STEMI.
Yeah, I mean, I think that's a joke, but it's fairly serious, right? You can't.
I mean, we're getting there. I mean, I think that we're really getting close to being able to merge these different data types. And we say, oh, the computer can only tell us something it knows about. Well, we're going to find more ways for the computer to independently gather this data, and then it's really going to start to be able to replace us.
I think not to end on a scary,
a dark note,
Judgment Day Terminator note here. Anything is better than what we do now. Like literally, we get every person that has a chest who presents to the emergency department gets an EKG and gets it signed, right? And so even if you can reduce the burden a little bit, this would be a valued tool.
Well, I will say though, I used a Google Notebook a couple of months ago to make this podcast automatically, and it's not very good. You may think we're bad, but man, if you listen to Google Notebook try and analyze a paper, it's a step down for sure.
We're better than Google Notebook.
We're not as boring and dry. They may be more accurate, but it's pretty dry.
They don't have the wow factor that we have, huh?
Yeah, there's no Riz. Google Notebook ain't got no Riz.
All right. I think on that note,
Google Notebook won't descend into this sort of madness, though. So you'll never have to put up with this at the end of your podcast. Yes,
all right.
the dark future of AI.
All right. Well, on that note, I think we'll wrap up for the month. As always, any comments, questions, or concerns, we can be reached at annalsaudio@acep.org.
Questions, comments, or concerns, or if you'd like to see us replaced by AI, send an email to annalsaudio@acep.org.
Otherwise, until next month, it may be us or apparently Google Notebook. This was Ryan Radecki and Rory Spiegel, and this was the Annals of Emergency Medicine podcast.